The Curbsiders are now partnering with VCU Health Continuing Education to offer CE credits for physicians and other healthcare professionals. Check out curbsiders.vcuhealth.org for more information. And please join us this Tuesday, February 12th at 8:30 p.m. Eastern Time. We will be doing a live COVID Cakes Journal Club featuring our resident epidemiologist, Rahul Ganatra. You can interact with him and with the host, ask questions. It's going to be a ton of fun. We hope to see you there.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Memorial Hospital and its affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Well, Paul, this was a really good one. I'm really excited to get to the show. Of course, we're talking about the inpatient side of alcohol use disorder, specifically withdrawal. And we had a great guest tonight. This is the Curbsiders. Paul, can you tell people, what do we do on this show?
Well, of course, Matt. We are the Internal Medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge, and this is a great one. The great Dr. Nora Taranto has brought us an outstanding guest to talk to us about the management of inpatient alcohol withdrawal. So, Nora, what did we learn?
We learned so much. Oh my gosh. We learned how to screen patients to try to figure out who's at high risk of withdrawal, who actually needs to be admitted to the hospital, which was something I wasn't super comfortable with, who can be sent home, and also learned about kind of what the different withdrawal management protocols are, as well as how to safely transition people out of the hospital when they're ready.
And we learned I've been wrong about alcoholic hallucinosis for about a decade now, which is always pretty exciting to find out.
I bet you like most of the audience is with you there. Dr. Joji Suzuki MD is an addiction psychiatrist at the Brigham and Women's Hospital in Boston, Massachusetts. He is passionate about improving the way we identify and treat patients with substance use disorders and has spent most of his career as an inpatient addiction consult liaison psychiatrist, where assistance with alcohol withdrawal management is a common consultation question. And Dr. Suzuki is just delighted to be here today so that he can talk about alcohol-related issues to our broad audience, given that inpatients with alcohol problems are common, yet their alcohol use doesn't always get the attention it deserves. So without further ado, here's our conversation with Dr. Joji Suzuki. Okay, Joji, thank you for bearing with us through some early technical difficulties. We're really excited to have you on the show. Can you give the audience a one-liner about yourself and tell them maybe a hobby that you have outside of medicine?
Sure. So my name is Joji Suzuki. I'm an addiction psychiatrist here in the Academic Medical Center in Boston. I'm pretty passionate about improving the treatment of substance use disorders. And one of my hobbies would be indoor rock climbing.
That sounds like a great hobby. Probably right now, the rock climbing walls are all closed, so I'm sorry for it.
They are all closed, but it's an opportunity to actually go outdoors and find outdoor rock climbing places. Actually, that's been fun. I do it with my younger son, who's only 7, but he's a better climber than I am. So
it's probably hard to stop him from climbing if he's 7 years old. That sounds great. Oh, yeah. That's a great hobby. Oh, yeah. All right, I will defer to Paul Williams.
Yeah, we'll add this to, once again, the list of guests who have way more exciting hobbies than I have. So good for you, which I think actually at last count is all of them. I'll go to my usual questions. So I'd like a book recommendation from you. Does not have to be medical, can be fiction, nonfiction, but just tell me a book that you enjoyed recently.
The one that I actually have read a couple times that I really like is by Edward Deci, Why We Do What We Do. And it's really about behavior change. And I feel like a lot of what we do as healthcare providers is to help change behavior. And Edward Deci and Ryan out in University of Rochester have written a lot about their work around why people decide to change behavior or adopt certain behaviors. And it's quite fascinating. And it's a short book, Why We Do What We Do. And I think it's a great read.
That's a great recommendation. That sounds like 90% of primary care is what you're talking about there. So that sounds wonderful.
Exactly.
Another question that we like to ask is, what was some great advice that you've received during your career that you found helped you along the way? Could be when you were a trainee or now that you're an attending.
One that really that has stuck with me for a long time is a advice that I got from one of my research mentors. And it was early in my career, and the motto that she taught me was start, finish, deliver. And any project that I'm trying to sort of think about, I should always think through starting it, finishing it, and delivering it. The final delivering part is some kind of dissemination, whether it's a paper, presentation, poster. You don't want to keep it to yourself. Obviously, scientific progress relies on dissemination. And so, anytime I was going to agree to a new project, I really thought carefully, can I really finish and deliver? So, that's been a really helpful advice that I've had that I stick to this day.
That sounds like that is really great advice. I think we probably can all think of people that are good at starting things, but not necessarily the finishing or delivering part.
Yeah, exactly.
Okay.
We have a lot of, half-baked sort of projects that never went anywhere. And, that's part of it, but I think we should try to minimize that. Yeah.
This is all starting to feel like an attack, by the way.
I didn't mean you, Paul. How could I mean you? You get so much done. Speaking of you, Paul, it's been a while since we've had one, even though we've recorded a ton recently. So I just wanted to hear a pick of the week from you before we go on to the main topic.
Oh, gosh, a surprise pick of the week. All right, great. Yes, I can do that. I'm going to recommend a movie I just was watching over the weekend. Probably most of you have seen, but I'm going to chide you for not remembering exactly how great it is. And I think that'd be the Coen Brothers movie Fargo, the 1996 classic. It is so good. At one point, I was just jumping up and down. Just as a refresher, it's the main character. His name's Jerry Lundgaard, played by William H. Macy, and probably his best performance, about a guy who basically hires two small-time crooks to kidnap his wife so he can actually get the ransom money and split it with them. And then things go south in the most complicated way. And it is just one of the smartest, most beautifully put together, best written film that loves its characters. And yet it's dark, it's funny. It is an almost perfect movie. So if you've not watched Fargo recently, go out and watch that.
Paul, it's just shocking to me that you do these off the cuff. It's just great. I don't even want to try to follow that. I would just like to go to a case from Cashlack. And I have to point out, I was thinking about this. Our show, Joji, our show has become known for bad puns. And one of our co-hosts who's not here tonight, he's on the front lines fighting COVID right now, but he tells bad puns on every show. And when Nora started working with us, our wonderful writer and producer for this episode, she started putting making the names into puns. And I think we have to blame you for that, Nora. I'm pretty sure it was you. I don't think it was Stuart, Paul. And Paul always just groans every time these names come up.
Right. Well, I feel like this is prelude to our first case is what I'm hearing here.
Yes. So Mr. Al Kahal is a gentleman admitted to you on the general medicine service. He has a flutter. They're planning an ablation tomorrow by EP, but there's no beds in cardiology, so they send him to the general medical ward. He has hypertension, some ulcerative colitis. He's on a DMARD, and also some depression, anxiety, some chronic pain. And, he's on your service because they don't have beds. He states that he had a drink about 6 hours ago with lunch, and he doesn't really identify any alcohol problem. So in the hospital, I've seen places say that universal screening should be done. What do you think is the best way for our audience to identify alcohol use disorder in the hospital?
Yeah, great question. Historically, we were taught about the CAGE questionnaire, and that's really fallen out of favor because the CAGE questionnaire was really targeting people with heavy drinking, alcohol use disorder, people who, the eye opener, which would be, drinking in the morning. That's typically to treat the withdrawal that occurs in the morning. But in reality, actually, in the hospital setting, there's an entire spectrum of alcohol use. And there's a huge number of what we call at-risk drinkers. And these are people who may not meet the criteria for an alcohol use disorder, but are still drinking heavily and typically in a binge pattern. And they have a lot of, injuries that are associated with it, falls, car accidents, assaults, etc. And from a hospital, perspective, we should be actually identifying both categories, at-risk drinkers and people at risk for severe, withdrawal et cetera, who need actual addiction treatment. Because it turns out that the intervention for average drinkers can be pretty minimal, but the impact is very big. From a public health perspective, we should be targeting both. So the tool that we use that we recommend is Audit-C, Alcohol Use Disorder Identification Test Consumption Question, or the first 3 questions of the full 10-item audit questionnaire.
Now, with this gentleman, clearly the case is written. We're worried he had a drink 6 hours ago. It's like the classic, he doesn't think he drinks that much, but he was drinking at lunch, and we get the suspicion, eyeing him up like we think he's probably not telling us exactly the extent of it. And this is always a big question in the hospital. Like, how do you predict his risk for going into like a severe withdrawal, and do we have to start to worry about that?
Yeah. So the way I think that seems to work the best is to have a pretty low threshold for placing somebody on a symptom-triggered management protocol. One way is to use the Audit-C score, have a cutoff. It could be 4 or 3 or 5, somewhere in there is probably the appropriate number. A little higher for men and a little lower for women. And then if you screen above that cutoff, then simply have that person be monitored with a CIWA scale. And if they score low, nothing happens. But if they score high on the CIWA scale, then they get medicated. And this approach ensures that people who may need treatment will get it, but the majority of people who may be drinkers but don't need any pharmacologic management for their withdrawal. Because in the hospital setting, disproportionately what happens is people get too much benzos. And so the symptom-triggered therapy should be the default strategy. And it's a sort of a safety mechanism. In case they manifest withdrawal, they get medicated. And if it's not that severe, you leave them alone.
It feels, at least anecdotally to me, like there's a lot of variability. You can have someone who will drink the fifth of vodka every single day and be able to stop and be without any kind of issues at all. And you have someone who has comparatively less drinking who might seem to go into withdrawal fairly rapidly and sort of surprisingly. Is there a way to kind of predict what someone's withdrawal is going to look like or who's going to go into withdrawal?
Yeah. And, I see that's $1 million question. And most of my career I've spent doing inpatient addiction consult. And that question has been asked many, many, many times over the years. And it turns out it's sort of like predicting suicide. There are many, many risk factors associated with it, but applying that to a single individual is really hard. And the only thing that I truly feel, and this is, largely supported by the evidence base, is that the one thing that is probably the best predictor is prior severe withdrawal. Now,
yeah,
so that's probably the best predictor that we have. And so, but of course that gets tricky because there's a lot of misclassification that occurs as well. People think they had bad withdrawal, but it turns out maybe they just had too much benzos and they were sent to the ICU because of that. So it's not a perfect, predictor, but that's probably the best one that we have. And so what that means is we tend to be, we're on the side of caution because it's hard to know who's going to have bad withdrawal.
Nora had found there was a rational clinical exam article for severe alcohol withdrawal, and there was this PAWS score, PAWSS, and they said the likelihood ratio for a PAWS score greater than 4 was like something off the charts, like over 100. And it's basically asking, like, has this person had severe withdrawal? And it also includes some things like, are they intoxicated at the time, or what's their blood alcohol level, rather? Do you use that clinically? I know a lot of the clinical scores, like, it seems like people that do this a lot just internalize them and don't tend to do the scores as much as people that are more novice and not doing it as often.
PAWS is not a bad tool. I've worked with a guy who developed it, Jose Maldonado, out in Stanford, and he's a great, smart guy. I just don't, I think doing the Audit-C, which is shorter tool, it's easier to incorporate into the regular workflow of nurses. The CIWA method is well established. So I think there are multiple ways you can do it. I think PAWS is a good tool. But if you look at the tool, it's simply asks, have you ever had a drink before? And, then bad withdrawal, prior treatment, blackouts. Again, these are pretty common clinical questions that we ask anyway.
Yeah.
So I'm not sure that we have the definitive tool just yet. Plus the study that they did was a very small study. So it's hard to make definitive statements based on that alone.
I had asked about universal screening. when patients are admitted to the hospitals. And I know some places, near Cashlack, Northeast, that actually do a universal screening for substance use disorder when patients are admitted. But it seems like you really have to have the training of your frontline staff. Usually the nurses are the one asking this. And then you have to have like the addiction chops to back it up. Because like, what if you find it? Yeah, for alcohol, you can kind of monitor for withdrawal. But for some of the other substances, I don't know how practical it is right now for everybody to be doing the universal screening.
Yeah, universal screening for drugs in the hospital is currently not recommended because we don't have good tools, first of all. And second of all, I don't know if you guys have heard of the term SBIRT, screening, brief intervention, and referral to treatment. And for a time, that was like the hot thing in the field, like SBIRT this, SBIRT that. If we just did SBIRT for everything, we'll solve all the addiction problems in this country. But it turns out, SBIRT worked really well for at-risk drinkers in the hospital, trauma unit, and emergency room. And so people got really excited and adapted that to heavy drinkers and drug users, the vast majority of studies have failed, suggesting that simply identifying people and doing a brief intervention, referring to treatment alone is insufficient for unclear reasons. We don't have a good sense of why. But the addiction consult sort of model, I think, has begun to change that. The idea that we can simply talk to a person for 5 minutes and say, oh, go get treatment. That works for people with mild drinking problems. But for people with severe problems, that's simply not enough. So we don't have a good answer for what should we be doing for, other drug users in the hospital. Should we be doing universal screening? That's still an ongoing debate. We think it's worthwhile having a system in place to identify people and having the addiction experts available to do more in-depth assessment and treatment recommendations, et cetera. But the reality is a lot of hospitals simply don't have that available. I don't know if Cashline has that.
Oh, yeah.
Cashlack
does not. I wish we were Cashland. We would have everything. That's our big sister hospital that we're all jealous of because I don't know, Paul, we should make a Cashland hospital that's our rival. I think this has legs, actually.
Yeah.
I think it does. Yeah. Yeah, we're very bitter towards Cashland.
Yeah.
They're always flaunting all their money. Yeah, they have all the N95s in the country right now, too.
Yep.
Yeah.
Right. They're hoarding it. Jeez, yeah.
Okay, so this is a question that we had talked with Marlene Martin, Dr. Marlene Martin, about more of the outpatient treatment. But I think this question's a little bit pertinent. Maybe you have an answer to it. When you're trying to decide, can this person be sent home for outpatient treatment or inpatient treatment? Is the question that much different than who do you think is going to severely withdraw?
I'm sorry, are you asking if the person's to be admitted inpatient for the treatment of the alcohol withdrawal?
Yeah. Like how do you sort of decide like which patients, like let's say this guy's like, oh, if I'm not having my surgery, I just want to go home. How do you sort of decide like which patients are going to have severe withdrawal and can be treated as that have to be inpatient and which ones can be sent as an outpatient and maybe given some outpatient therapy for that?
Yeah, that's a great question. We're actually trying to implement that right now to try to minimize the number of people being hospitalized for alcohol withdrawal. And so a couple of factors that we look for. Number one is absence of any prior severe withdrawal, obviously. CWA scores less than 10 is probably a common cutoff that we use. Anything above 10, we don't want to really be sending those patients out. No concurrent sedative hypnotic use disorder is a big one. And people who are not coming with very, very high elevated BAL. Those are the main things that we kind of look for. And of course, a person who has a stable home environment, there's nobody else who's like actively drinking. Ideally, we have a sober support person who can help monitor. And a person who's relatively reliable, that they can be, take the medications on their own and potentially call the clinic or come to the clinic daily for assessment. That's the kind of thing we generally look for. And we would use Gabapentin, not benzos. So we would never send anybody out with benzos or phenobarb or any of that.
Right. I guess, Paul, have you ever treated somebody as an outpatient for alcohol withdrawal? It seems like maybe if you were primary care and you knew somebody really well and you could check in with them every day, then maybe. But I've never done it. I wonder if you've had.
I think, and maybe this is not a fair generalization to make, but I think the patients that I have that are sort of dealing with alcohol use disorder or have withdrawal symptoms probably don't have the kind of sort of social stability that I could get a hold of them every single day and make sure that they're doing all right. So I think that the patients that I would need the closest contact to are probably the ones that are kind of the hardest to get a hold of. So the short answer is no, I've not ever had the confidence to do that on my own.
Okay. I just had a couple follow-up just to clarify, Joji, some of the things you said. So the CWA less than 10, that was on the initial CWA score that you count. Like after you do your audit C, you say, okay, this person's at risk. You do your CWA. If it's less than 10, you could consider outpatient treatment if you go through that checklist and they seem to have some stable social support, no prior like severe withdrawal. They're not like also addicted to benzos using benzos. And then the elevated BAL, was that great? Is 200 the cutoff you use? Is there a specific one?
Yeah, we don't have a necessarily cutoff because when you get the BAL, kind of the number depends on when you get it and when you capture it. But if somebody has a BAL of 400, they're not going home.
Okay. Okay.
Like,
I like to make it binary. That's good. Okay. So if it's yeah, got it. All right. Thank you. That's really helpful. So it sounds like it'd be a special person. Like a special case, because a lot of the patients, working mostly as a hospitalist, a lot of the patients that I see don't meet all those criteria to be able to go home.
Yeah. But, we've been so accustomed to hospitalizing anybody who seeks alcohol withdrawal that there's a lot of resistance to actually doing ambulatory detox. And so we were actually going to implement a pilot study at Cashlack to see if we can send some of the patients home and using a sensor device to monitor people. But the IRB would not let us do that. There's still this really ingrained mentality that alcohol withdrawal must be managed inpatient, and the risks are too high to send them home.
So, Joji, I wanted to go back to the case of Mr. Alcohol here, and let's say that I seem to get in this position. Maybe this just says something about me as a clinician where I'm not doing things correctly, but I get in this position where I see patients that have known alcohol use disorder and have history of severe withdrawal, but they're not ready to quit drinking and they're not yet in severe withdrawal. Maybe they're on their way there and they want to leave the hospital to go drink. Maybe they've gotten some fluids, some nausea medicine, some antacids for gastritis and maybe a dose of like benzos, but they're not intoxicated or sedated. Do you ever let those patients leave the hospital if they're just not there, like ready to meet you?
Yeah, that's a great question. The way I would put it is everything doesn't have to happen in the hospital. And for some patients, hospitalizations are extremely distressing. It's not a fun place to be. They feel judged. Their normal coping strategies, their support system isn't available. And their cravings to use could be, pretty high. So I generally don't like to get into battles with patients about, staying to complete their withdrawal management or not, especially if they're going to say they're going to go out and drink anyway. But I would argue that every one of these encounters can be used as opportunities to, build a relationship, encourage people to seek treatment, because motivation to get help is it's not yes or no. It's a constant struggle. And we have the ability to actually influence that, on a day-to-day basis. And so ideally, there's a team in place that can actually support these patients outside the hospital. So, for example, we have a bridge clinic. I guess the bridge clinic is at the Cashland.
Yeah, it must be.
Sure.
Anybody with a substance disorder can be seen with or without an appointment. They can just walk in. They can come in to just have coffee and donuts. They don't even want to have to get sober. If they just want to engage with us, we're willing to do it. We have recovery coaches that are people who are in recovery themselves and are able to work with patients in the community. So we can work with people, whether they're in the hospital or in the community, whether they want to stay sober or not, and sort of meeting where patients are at. And I think because, patients get the message that they either have to quit or they're not motivated. That's too simplistic in a way. I think we have to find a way to support our patients no matter where they are on that path towards recovery, which oftentimes takes many, tries. It's a circular effort. It's an iterative process. And our healthcare system is really not set up to sort of support our patients through that journey.
I think Matt and I talked about this on a prior episode. I feel like opioid use disorder has become kind of the model. It's because of, I think how prevalent it's become and how much we sort of talk about and discuss it. And so I think everyone is kind of on board for harm reduction. Maybe not everyone, but lots of people are on board for harm reduction. And I think we can kind of agree that less use is better. And yet for some reason, if you just pivot to alcohol, it's still, a lot of people conceptualize that as almost an abstinence only model and don't think about just less, still like the harm reduction model for some reason is not applied to that,
right,
to this particular substance. And I just find that fascinating. I don't have an answer.
Yeah, and I feel like for alcohol, man, I think it's really hard to get sober in this country, right? I mean, there's alcohol at every corner, street corner. Every social event, is kind of centered around alcohol, right? And so, I think it's really important for us to recognize that even with a lot of motivation, it's really hard to get sober.
Yeah. So if you met the right patient, you mentioned discharging patients on gabapentin. What does that look like? How long are they going to be on it, and what sort of doses are you using?
So there's two ways to use gabapentin here. It's for withdrawal management and also maintenance. And so for both, actually, we're looking at somewhere in the range of 1,800 to 2,400 per day is going to be your typical dose ranges. And there are plenty of studies that show that 1,800 is sufficient to manage mild to moderate alcohol withdrawal. And that's probably the kind of dose we're going to be looking at for maintenance as well. And if they just want to use for detox, we're just talking, we're looking at a couple days. But if it's for maintenance, we're looking at however long the patients are willing to take it.
Is it a taper when you do it for detox? Like you start at 2,400 and then go down by so much each day over like 5 days or so?
You can do it. You can do up titrating then down kind of a thing, or just starting straight at 1,800 and taper down over 3 to 5 days in that range.
Okay.
And patients tolerate that dose okay?
They do, especially if they're drinkers, so
sure.
You want to warn that, if it causes sedation, then dial back.
And I imagine if someone has another substance use disorder, opioids or benzos, they might not be an ideal candidate for this kind of thing. Isn't there some signal for like increased overdose risk with using like gabapentin and these other agents?
Yeah, very good. Opioids. So that's when we get worried. People with the opioid disorder do misuse gabapentin for, it potentiates the subjective effects of both opioids and benzos. And so you're absolutely right. At the population level, gabapentin, pregabalin, Z drugs, they all slightly increase non-fatal and fatal overdoses, especially for opioid users. So we want to be much more careful in that population. But if they're not opioid users, gabapentin is probably relatively safe medication to use.
So, Paul, do you think we should make Mr. Alcohol a little sicker and then talk about the inpatient stuff, or is there more of the kind of on the fence of inpatient versus outpatient that we should talk about?
No, I think for sure we should make him sicker. So let's say, if you don't mind, Matt. So let's just say that Mr. Cahal, is that what we went with?
Yeah, I think so.
Sure. So let's say we do a shoddy job of doing an assessment early on, and then we go back and he starts to exhibit maybe some signs of withdrawal. So we go back and take a better history. What things in the history or what things on examination should make us think that he actually might need a higher level of care for his withdrawal symptoms than just regular inpatient? So I guess what I'm asking is, what would make you think that someone might need an ICU level of care for alcohol withdrawal symptoms?
Yeah, so if they're already in DTs or, severe alcohol withdrawal, then the consideration for ICU level care should go up. If you're having to give meds every 1 or 2 hours, for example, then at that point, probably warrants something, much more controlled, like an ICU setting. Obviously, if they can't maintain airway, all that kind of stuff. But see with scores that exceed like 20, you're starting. I would be much more worried, especially if they're that high, despite getting a lot of benzos, and deteriorating condition also. So the first 2 days of withdrawal is really, I see, as a golden period. If you can manage the withdrawal adequately during the first 2 days, then the risk of that developing into DTs is extremely small. You're never going to see 2 days of perfectly well-managed patient, low CWA scores, tolerating the benzos, and then day 3 suddenly they're delirious from alcohol withdrawal. That's not how it happens. Generally, how it happens is insufficient control early, and there's a ramping up of these symptoms. In day 2, day 3, now they're getting delirious and they're looking toxic. So as long as you do a good job in the early course of withdrawal, adequate early treatment will prevent the development of bad withdrawal. But if you're not treating it well, so for example, if I'm on a case where I see that the first day and a half, the guy got nothing, If Mr. Alcohol got nothing, no benzos, maybe like 1 milligram of lorazepam, and that's all he was getting, and you look at the CWA scores, they've been escalating the last 2 days, then I'd be very worried. Because once you're behind, it's difficult to catch up. And that's the biggest downside to the CWA symptom-triggered therapy, is that when you become behind, then you're being very reactive, and it's hard to catch up.
Right.
I seem to run into some of the patients where it seems like they're getting underdosed, maybe because some of the staff are unfamiliar or afraid to give the medication, or some patients are just like seem to be too sedated. What do you see as like the biggest pitfall, and maybe if you have any suggestions for us how we can coach our teams in the hospital through that?
Yeah, great question. I actually feel like the bulk of the patients are managed relatively well if you use a symptom-triggered therapy. But so there are certain criteria that you escape the symptom-triggered therapy. If they're delirious already, prior history of bad withdrawal, very elevated CWA scores, etc., then the symptom-triggered therapy is not appropriate anymore. So they have to be in a fixed dose regimen, whether it's with benzos or phenobarb. And that's when you have to sort of proactively decide how much to give. And if you have a team that's not necessarily that careful with it, the symptoms of over-medication may be interpreted as worsening withdrawal. So then they get more benzos, and that can make things worse. And so we see that far more commonly than the opposite. And so we used to always joke as a addiction consult service that, like in the time that I've been practicing inpatient addiction consults, we can count in our heads how many times we actually told the team to give more benzos. Now, that actually changed when phenobarb got introduced. When phenobarb got introduced, we actually did see people were very nervous about using it. So on a regular basis, we had to recommend giving more. But it's pretty rare that we actually told teams to give more benzos. So it's pretty easy to teach our trainees. If you have an alcohol withdrawal case, just tell them to cut back on the benzos. If it's opioids, we don't have to tell them to give more. So it's pretty easy. The decision making is easy for our consult service.
Some of the stuff that you said there that sort of had me thinking. You said if they have a history of severe withdrawal, like let's say they have a history of DTs, they have a history of withdrawal seizures, and they're looking like it's not going to go well this admission, like they're already looking tremulous and a bit tacky. You're saying that's somebody that you would do a fixed dose regimen on?
Yep. You would start there. You wouldn't start with a symptom trigger. You would start with a fixed dose regimen, and you have to make a decision. Do we do benzos or do we do phenobarb?
Okay.
Really, it's still an unanswered question in the field. Is the phenobarb better because of the pharmacologic properties, or is it better because our benzo protocols were really lousy? And the phenobarb is generally implemented as a loading strategy and a weight-based loading. So, for example, the way we use phenobarb is to simply look at the weight, look at their risk for respiratory depression, and you get a range of dose to use. And then you give that TID IV day one, and then you're done. Phenobarb is a very long-acting drug. You let it self-taper. If they need additional PO taper, they would get it. But you're done just by simply loading. And in fact, that's how we used to manage alcohol withdrawal or barbiturate withdrawal years ago. So people that I talked to who practiced 30 years ago remember doing this with like barbiturate withdrawal. They would load somebody up with phenobarb. They would wait till they would manifest symptoms of, intoxication, slurred speech, nystagmus, and then you're done.
Right. Didn't they used to do like phenobarb comas? Like they would just load with phenobarb, and then when they wake up, they'd be tapered essentially. Yeah. And
so different hospitals might use a similar loading strategy with phenobarb or diazepam. But in our hospital, we do a fixed dose regimen where we, give a certain amount and actually recommend a fixed taper. And I think that leads to over medication. And so I think the loading strategy, if we used it, I feel like both diazepam and phenobarb might be just as effective.
Okay. So I see a lot of variation in practice, and every hospital I've worked at has had its own protocol for this. Do you recommend that people follow the protocol from their local hospital? It seems like these are high-risk meds we're talking about, and certainly I don't have much experience with phenobarb because usually those patients are in the ICU when they're getting loaded with phenobarb. Can you talk us through, like, how do you think our listeners should choose, like, what to do when they're approaching these patients?
Yeah, I mean, I think having a standard protocol that you can sort of modify, I think is really important. Because like you say, many hospitals actually, if there's no standard protocol, every team will do it differently. So this is a nightmare for the nurses, like for each patient, the actual dose that they give is different. The PRN, recommendations are different. And so I think having some consistent approach across the hospital that all the nurses get trained in how to manage, I think is very important. And then you can begin sort of adjusting based on that. So yeah. And there's always institutional preferences, right? Like at Cashlack, people do not want to use diazepam. We've recommended diazepam so many times, they stick with lorazepam. And I know there are other institutions where they'll stick with, other benzos. Some still use oxazepam. We actually do not recommend oxazepam. We don't think it's actually a safe benzo to use because it's a very short-acting medication, and it can actually cause some problems itself. Anyway, so there's institutional inertia around these medication choices. So you just have to get comfortable with whatever they're using.
Okay, so I do want to jump in and talk about some of the specifics of benzos in a second, but just before we leave phenobarbital, I seem to have seen some patients where they've been in the ICU and I'm not exactly sure what they're getting down there. Maybe it's the loading dose that you're talking about, and then they come out to the general service once they're doing better, and they're still on phenobarb at some sort of an oral taper. Is that something that can you tell us a little bit about how that might work and how quickly we can taper? Is there any sort of standard way to bring that dose down, or does it self-taper, as you said, and is that just a waste of time?
Yeah, I mean, the PO taper generally is not required for every patient. If you did the loading appropriately, the PO taper is not necessary if they're not showing any symptoms.
Okay.
Still, showing symptoms like tremors and tachycardia, et cetera, fine, give a taper. But you're talking somewhere in the range of 3 to 5 days. Again, as long as we're saying we had adequate early treatment, then the tail end of it, you can kind of do all kinds of things. But 3 to 5 days is probably sufficient.
Okay.
But the predominant problem is over-medication. With phenobarb, I think people have an easier time withholding because people get so scared with it. But for whatever reason, people have loved to load people with benzos.
Yeah, so the benzo stuff, I guess like you at Cashlack that I work at and have worked at, I've been in a lot of hospitals at this point in my career, and they've all just by chance used lorazepam. Is there, between lorazepam, diazepam, and chlordiazepoxide, which is hard to say, why do you think, are there certain reasons people choose one over the other, and why do you specifically like diazepam best?
Yeah, I think diazepam provides the smoothest withdrawal. However, obviously it can accumulate. Hepatic, impairment can cause problems. Diazepam is a little bit more like a faster onset, so the initial kinetics actually contributes to the liking of it, and so there's a greater misuse potential. But other than that, I feel like lorazepam actually would be safer if you had to pick one, because obviously it's a short-acting benzo, no active metabolites, that sort of thing. But I think the diazepam, the quick onset, very easily absorbed. It's a good benzo. But diazepam or lorazepam, I think both are fine.
Mm-hmm. Do we have to worry about IV to PO conversion with those? Is it 1-to-1 with diazepam since it's well absorbed?
Yeah. Most benzos, the bioavailability for the oral is going to be 80 to 90%. As long as they can take PO, it's not that different at all.
It's not that different.
But the biggest concern would be somebody who's a heavy drinker. They can have a lot of gastric irritation that can impair absorption. Most patients, you might want to, favor IV or, increase the dose for PO.
And you mentioned liver dysfunction. With the benzos, is there one that's better than the other? I was trying to look this up a little bit today, and I was getting confused for some reason. I was probably just looking in the wrong places.
Yeah, I think lorazepam is probably the safest one to use. And again, oxazepam is a commonly used benzo for that purpose. But because it's even shorter acting than lorazepam, it actually can cause what's called late onset seizures. So we think about alcohol withdrawal seizures occurring within the first 2 days after cessation, right? But if you do a detox with oxazepam, these are studies from the 80s, 70s, after the completion of the taper, the 2-day period after that, a proportion of patients can actually have seizures. It's called late onset seizures, and it's been demonstrated with oxazepam. Now, I've seen that actually happen with other benzos, but since there is a study that's showing that oxazepam can cause it, I just feel like lorazepam is a safer medication to use.
I'm not sure if this is the place for this, but because I feel like you touched on all these points kind of just peripherally about the conversations we've been having, but let's suppose for a second that we're completely incompetent. We did not do a substance use history at all. The patient becomes agitated and tachycardic, and we just let him go because we're lazy or we're overwhelmed or we're dealing with COVID patients. Could you just sort of talk me through kind of the natural history of how withdrawal progresses? Like go through, what we could expect if we just did not treat the patient off, we failed to prevent anything with all these medications we're talking about. So
right.
Close stenosis versus DTs versus withdrawal seizures, like how do they all interrelate?
Of course. So the vast majority of patients, if you did what you described, will be fine. They're going to go through a period of 2 to 3 or 4 days of discomfort, of mild withdrawal symptoms, headache, nausea, anxiety, restlessness, insomnia, maybe mild perceptual disturbances, but nothing serious, lots of cravings, but it's self-limiting. I was out in a Navajo reservation a number of years ago and to help with their addiction treatment out there. And they don't really have much. Actually, they have nothing except for one clinic affiliated with the Indian Health Services. And what I learned is that every Monday morning, the police will drop off a bunch of people at the clinic because they're all picked up, over the weekend who are public intoxication or drunk driving. And they really don't have anything else. So they just get dropped off Monday morning at the clinic to get checked in. And 100% of the patients at that clinic are mandated patients. None of them were there for volunteer. They're all sent there by the police. And after the intake, so they're all waiting in line Monday morning. They're all shaking and, in withdrawal and doing their intake process. And I was like, so I was kind of stunned, right? I'm like, this doesn't feel safe at all. Like, how often do you have to send patients to the emergency room because they're having bad withdrawal? And they're like, maybe once or twice a year. Meaning the majority of them are going to be fine. They're heavy drinkers. They're not going to have severe withdrawal. It's uncomfortable, but they're not going to end up in the hospital because of that. Some will. So this is a challenge, right? We don't really know who's going to have that bad withdrawal other than asking prior bad withdrawal. And so most of them are going to have a self-limiting mild alcohol withdrawal that's uncomfortable, but it's not going to lead to a whole lot else. But for those who do have bad withdrawal, the first 2 days is when you have the, seizures. And then past that, after 2 days is when the delirium really sets in. And if untreated, mortality rates can be as high as 20, 30, 40%, which can persist for 5, even longer. Elderly, it can probably last even longer, 5 to 10 days untreated.
Yeah.
And one thing I'll also point out is that I think it was in the script, and this is a frequent misunderstanding, is alcoholic hallucinosis. That's often sort of commented in the context of severe withdrawal. It's actually not a withdrawal syndrome. It tends to begin during withdrawal. But the definition of alcoholic hallucinosis is persisting perceptual disturbances past the withdrawal. And in fact, the treatment is not benzos. Treatment is actually antipsychotics. And it's a distinct process from a psychotic disorder. So it's not simply a psychotic disorder, manifesting itself. It's a different disease altogether. And so, it's oftentimes conceptualized as a part of a severe withdrawal, but it's actually not.
Holy cow.
Did not know that.
Had that wrong for now a full decade, so that's
right. And that, because the treatment is antipsychotics. Benzos don't make it better.
Gotcha.
And I was reading that the hallucinosis is they have normal attention and cognition versus delirium tremens. The
Correct.
Hallucinations they'd be delirious and not making sense. And
correct. And DTs, it's a true medical emergency. People look toxic. They don't look well at all. Alcoholic hallucinosis, people can be pretty calm, and they'll say, oh yeah, when I stop drinking, I start hearing voices, and they start, berating me. Oh, Zyprexa takes care of it, that kind of thing. Oh, olanzapine will take care of it, that sort of thing.
Joji, when I was looking into this, that one of the questions I wanted to look into for preparing for this was the whole banana bag thing, because there was some people I remember on Twitter kind of like bashing the fact that banana bags are not used, and I thought it was interesting. The point that they were making was that there is thiamine deficiency in patients with alcohol use disorder pretty commonly, but the banana bag takes a very long time to go in, and you can give the thiamine, like the 100 of IV thiamine, much quicker, and just kind of like you can give the components separately. You don't have to necessarily give them this, the multivitamin, I believe, is what gives it sort of the yellow color. But how important are the electrolyte abnormalities? Maybe that's out of your scope as the addiction psychiatrist, but do you get on the primary teams, have to remind them about that, or do you have any general guidance there?
Yeah, for the thiamine, definitely. The medical dogma for many decades throughout my training has been give the banana bag, which is 100 milligram of thiamine IV, right? And I guess I didn't appreciate that giving it an IV push versus a bag is a hassle. But actually, so a couple things. We know that people who drink heavily are thiamine deficient at baseline. They just are. And we learned in medical school about the classic triad of Wernicke's encephalopathy, ataxia, ophthalmoplegia, and mental status change. But the vast majority of people who have thiamine deficiency actually don't manifest that classic triad. And based on autopsy studies, we know that people who have heavy drinking, who were never diagnosed clinically, actually have histologic evidence of Wernicke's or other damage to the brain from thiamine deficiency. And what we also know is that after the initial thiamine IV is given, people are simply given PO thiamine as a sort of a continuation of the thiamine. And so I think what's pretty clear at this point is that the initial 100 milligram thiamine is great, but it's probably not enough to reverse the deficiency. And the PO thiamine that comes after is completely useless. It completely saturates the active transporters in the gut lumen, so most of it is not even absorbed. And even if it's absorbed, the thiamine has to go from the blood, from your circulation into your brain, past the blood-brain barrier. And the only way to really drive thiamine into the brain is to change the concentration gradient between what's in the circulation and in your brain. And the best way to do that is high-dose IV thiamine. And so that's the current standard of practice. There are some studies out there, not great studies, but the high-dose thiamine is probably the way to go. And it took some time for people to sort of accept that. And because the argument that we make is IV thiamine, even high dose, has essentially no risk. It's a vitamin. We know that people are deficient. Let's take that out of the equation. They may not have actually Wernicke's, but let's just buff them up before they leave. And so I am a true believer in making sure that we give people adequate thiamine, because many of these folks are. But if they have a severe drinking problem, many of them are not eating at all.
The high dose is the 500 3 times a day for 2 days, and then something. Do you know the regimen offhand?
We recommend anywhere from 2 to 500 IV TID for a couple days.
And then can you go to oral after that for just like a maintenance dosing? Or do you think oral is just like, or even a multivitamin? Do you even recommend that afterwards for the B6 and the folate and whatever else is potentially deficient?
Unless they have niacin deficiency, which is pellagra. And if they have that, sure, then that's a very different way to manage it. You don't give high dose niacin, you actually replete it over time. But if there's nothing else, I would just give the thiamine in-house, and then they don't need to take the multivitamins afterwards. I recommend that they eat.
So we're going to go back. We're going to go back to not being incompetent. We're going to go back to our baseline level of superb care and say that we prevented bad things from happening to Mr. Cahal. And he's expressed interest in maybe cutting back on his drinking and maybe even recovery. And so we consult our addiction services to sort of help with that transition. And I'm wondering, since this is one of your areas of expertise, what does that transition look like? How can we sort of tee patients up for success? And what have you done at your institution to make sure that that transition goes well?
Yeah, a couple things. I think we completely underutilize medications. I was kind of poo-pooing the medications a little bit, but we definitely should be utilizing it far more. And if there's access to the extended release naltrexone, that's a great medication to use. The manufacturer actually offers free shot per person per calendar year anywhere in the country, because they're so desperate for business. They offer free shots if you sign up for the program for a patient in a calendar year. So extended release naltrexone or PO naltrexone, any of the medications, great. We want to start it in the hospital. What I tell my trainees all the time is, if a patient needs to start an SSRI, like fluoxetine, it's okay that we defer to the primary care doctor to start it, right? The typical primary care doctor is perfectly willing to start fluoxetine, manage it, right? But if I ask the primary care doctor, typical one, I said, hey, your patient is being discharged today. You're seeing him next week. Can you start naltrexone? There's a very little chance that's actually going to happen. I've had primary care doctors refuse to start it. However, if we started in the hospital, it's pretty rare that a primary care doctor will say, no, I don't want to continue it. In fact, that becomes an opportunity to do some teaching and say, what are we trying to manage, the adverse effects and monitoring strategies, that sort of thing. So starting medications in the hospital, I think, is very critical. The other part is the linkage part, ongoing treatment. Medication alone is not going to cut it for alcohol. They're going to need a lot of support. It could be meetings. It could be more intensive treatment, whatever it is. The sooner you can get them connected, the better it is. If the appointment is 1 month out, it's just not going to work. So I mentioned the bridge clinic that we have at the Cashland Hospital. We some appointments on the day of discharge. We sometimes make appointments at the bridge clinic on the day of discharge. Despite that, many patients never make it, right? So we literally have to make it as easy as possible for people to make it to the next appointment. And some of the strategies we use are like, warm handoff. We might have the recovery coach meet the patient in the hospital, engage with them a little bit, and then actually literally walk them down to the bridge clinic so they show up. And if they show up, actually outcomes aren't that bad. We've been able to demonstrate that probably better with the opioid patients. Alcohol, not as good, but it's that initial linkage is so critical. So let's start medications, let's do linkage. And then finally, in the hospital setting, using motivational interviewing. To me, I'm very passionate about it. And it's a way for us to be able to demonstrate empathy and respect people's autonomy and to demonstrate compassion. But it's not simply about letting them do whatever they want. Those principles are used as a leverage to help guide patients towards change. So it's not this sort of, do whatever you want. It's more like, let me connect with you and then use that to gently guide you towards health. And so those are some of the basic elements I think are critical in ensuring that patients get connected to ongoing treatment.
And so in terms of the timing of starting the naltrexone, let's say you want to start oral naltrexone because the patient's not maybe willing to commit to the injection at that time. Where during the hospital course do you do that? Is it the day of discharge? Is it when they're done their benzo taper? Like, what's the appropriate timing of the initiation of naltrexone?
Actually, at the end of the detox is perfectly fine. In fact, the studies will recommend that 4 days of abstinence, so last drink and 4 days it actually improves the outcomes for both naltrexone and some of the other medications. It's not clear why. So it's perfectly okay to start these medications, well into the hospitalization or close to the time of discharge.
And then I guess my other question I would have is, during that, sorry to be taking up so much of the conversational space, but during that transition to the bridge clinic, when the patient arrives to that appointment, who is seeing them at that initial visit? Is it a psychiatrist? Is it a social worker, a peer recovery specialist? Like all the above? What does that look like?
Yeah, it depends on the person. It could be a psychiatrist. It could be a primary care doc. We have a mixture of providers: primary care doc, ID, physician, nurse practitioner, psychiatrist, and of course recovery coaches and a resource specialist. And so it kind of depends on what they're kind of looking for and where they're at. If they actually want to talk about medications, maybe the medical person is better. If they want to talk more about mental health issues, it could be the mental health person. So it kind of depends. We try to maybe match people to who we think would be a good match for them. We offer recovery coach to everybody if they're to work with.
Sure.
This is probably just availability bias, Paul, because of the circles that we are now running in. But I feel like people are now starting to take addiction more seriously, maybe because the opioid epidemic has touched so many people. And I'm hoping, I'm optimistic that maybe people with any sort of substance use disorder are going to get more and more access to resources like this, because you really have to help people fix so many different aspects. It's not just like prescribing a pill and then they're going to get better. It takes so much time and commitment, and people not abstaining fully and just getting back and trying to do their best to use less of whatever substance it is. But hopefully more of these clinics can pop up.
Yeah, although I would argue that these clinics are, that it's one part of the solution. but it's actually a larger failure of the entire system. To begin with, there's been a failure in the educational system, right? Medical schools, postgraduate training, nursing schools, education around substance use disorders is still fairly limited. It's different now. I think the last couple of years it's gotten much better. But prior to that, there were many medical schools that didn't even teach anything about it. And so what we have is entire generations worth of clinicians, physicians and nurses and otherwise, who really never got trained. They still got exposed to what we call the hidden curriculum. So they still observe their attendings, treat these patients in a particular way. They were pushed away, stigmatized, treated poorly, and that's what you internalize. And also, addiction treatment was never part of mainstream medicine, right? It's somebody else's problem. Now that it's coming back into the mainstream medicine, I think you're right. I think there's going to be, I think there's been more of a people taking responsibility for this patient population, but we still have a long way to go.
Joji, thank you so much. I hope you can get back to your family. You're recording in your car. You're one of our most dedicated guests ever.
Well, thank you. I appreciate you saying that. I'm glad I could be of help, and thanks so much. And yeah, if you want to invite me back, I'd be more than happy.
Yeah, let me monopolize your time for 30 more seconds. Did you just see the Kraken review that came out on Alcoholics Anonymous? Speaking of that,
yeah, John Kelly's work.
Yeah. Like that actually, I know that's, I think historically, they've just not been sort of amenable to being studied, but it looks like actually there's pretty great evidence now that AA is effective for maintaining cessation.
Oh yeah. I'm a big believer in AA, peer support. They've done so much good, and they need the recognition. And so I'm glad that John did that study.
Exactly. It's always, like, anecdotally, it's always seemed to be great for patients. It's nice to see evidence bear that out too. But Anyway, we should honestly let you go. Sorry.
Yeah.
No problem.
Please thank your family for your time. This is really helpful. Lots of people will hear this and find it incredibly useful. So thank you.
All right. Great. Thanks so much, guys.
Okay.
Have a good night.
Thanks so much.
Yeah.
Great to talk with you. This has been another episode of The Curbsiders, bringing you a little knowledge food for your brain hole. All right, fantastic. Get your show notes at thecurbsiders.com/podcast and sign up for our mailing list at thecurbsiders.com/knowledge food to get our weekly show notes in your inbox.
We're committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback, so please subscribe, rate, and review the show on Apple Podcasts, or send us an email to thecurbsiders@gmail.com. A special thanks to our producer for this episode, Dr. Nora Taranto, and to our social media team, Hannah R. Abrams on Twitter, Beth Garbatelli on Instagram, and Chris the Chew Man Chew on Facebook. Until next time, I've been Dr. Matthew Frank Watto.
I've been Nora Platt Taranto.
Thanks to the great Dr. Stuart Brigham for our theme music, and of course, thanks to Claire Morgan from Nautilus for editing. And I remain Dr. Paul Nelson Williams. Thank you and goodbye.
And thanks to our partner, VCU Health Continuing Education, who's helping us offer free CE credits for physicians and other healthcare professionals. Check out curbsiders.vcuhealth.org for more information.
Impressive you guys do this, like in your free time. Like are you guys?
Yeah, it's a whole thing.
That's awesome. You guys are pretty awesome. It's a lot.
Thank you.
That's very
very committed, dedicated people.
But I have to thank you you also came up with Cashland Hospital, which I am just really, that's
I'm
one of my
submitting
new
my
favorite.
application today. So long, suckers. I am off to Cashland.
How did we not think of that years ago?
They probably had like the
tweet this out
Starbucks
of-
machines.
Paul, I want you to tweet this immediately that we've thought of our arch nemesis hospital and who works there.